Good afternoon, ladies and gentlemen. So welcome to this afternoon's Alcon Dry Symposium. And it is with my greatest pleasure to introduce you to our moderator and first speaker, Professor Dr. Chi-Chin Sun. Professor Sun is a distinguished ophthalmologist and professor at Changgung Memorial Hospital in Keelung, Taiwan. He graduated from Kaohsiung Medical University in 1994 and earned his doctorate in clinical medical sciences from Changgung University in 2006. Dr. Sun completed his ophthalmology residency and a fellowship in cornea, external eye, and refractive surgery at Changgung Memorial Hospital. He has published over 150 peer-reviewed publications in the fields of stem cells, ocular surface diseases, keratoplasty, refractive surgery, and dry eye disease. Dr. Sun has held leadership roles, including former director of the Department of Ophthalmology at Changgung Memorial Hospital, and he currently serves as president of the Taiwan Society of Cataract and Refractive Surgeons. Please give us a warm welcome for Professor Chi-Chin Sun.
Thank you, Anton, for a kind introduction. I'm Chi-Chin Sun from Taiwan. I'm currently the president of Taiwan Society of Cataract and Refractive Surgeons. The topic today for my presentation is ocular surface consideration in cataract surgeries. I did receive an honorarium from Alcon. However, the presentation of my slide just reflect my own opinion, not relevant to Alcon company. Talking about ocular surface in dry eye disease, we have to know about the global trend risk of dry eye disease worldwide. As you know, the global prevalence of dry eye disease increasing. Some risk factor identified just like the Asian ethnicity, greater age, and female sex are also identified. According to my own study, we published in American Journal of Ophthalmology, we found that overall prevalence of dry eye disease is 7.85% and increasing with more predominant incidence in women population. Why is managing dry eye disease critical in cataract surgery? As everyone knows, that cataract surgery is the only preventable disease to prevent blindness in the elder population in many area of the world. However, an impaired ocular surface poses significant challenge when we plan for cataract surgery. Vice versa, cataract surgery alone can also exacerbate the dry eye disease. Therefore, a consensus of managing dry eye disease before, during, or after cataract surgery is essential. How does dry eye disease affect the cataract surgery? As mentioned, it poses challenges perioperatively, especially in accurate preoperative evaluation, including accurate IOL power calculation and estimation of the astigmatic axis and the degree is important. However, dry eye disease can also obscure intraoperative surgical field, interrupt the wound healing, and most importantly may disrupt or compromise the patient satisfaction after cataract surgery. So how does tear film stability impact on keratometry? There are accumulating evidence demonstrated that keratometry measurement may be inaccurate, greater than 0.5 diopter. Also, irregular corneal topography pattern may appear, and especially when we treat the patient beforehand, we can lower the refractive surprise in the pre-treatment group. This is another study also pointing out that when we pre-treated the dry eye patient before cataract surgery, the mean absolute error was significant decrease from 0.42 to 0.23 diopter after surgery. Also, the number of refractive surprise was significantly lower in the pre-treatment group. Let me show you a case. This is the 76-year-old gentleman who came for cataract surgery. He has the meibomian disease and a dry eye disease. And he asked for a premium lens explantation, to correct the astigmatism and also presbyopia. However, when you check the preoperative autorefractometry, you can find a significant discrepancy between the autorefraction and keratometry. So astigmatism major correlate poor with the refraction. To validate if it is right, we perform a series of examination, including the op-scan, the contact biometry, and again we found a discrepancy between these measurements. So did the biometry obtained by IO Master 500. So in this case, should you proceed with a toric IOL? I think the answer is definitely not. Therefore, we performed the surgery on this patient with just a single monofocal lens. However, post-op day one, the visual acuity was just 0.1. Certainly, she was not happy. But don't forget a dry eye, because the dry eye disease can, compromise the patient's satisfaction after surgery. Therefore, we adopt the aggressive treatment, including topical steroid, preservative artificial tears, tetracycline to treat meibomian disease, and lubricant eye gel. And when he came back 1 month later, visual acuity improved to 0.7, but he was still not unhappy and complained. 2 years later, you see the reflection here is quite good, and with glasses, patients' vision can improve to 0.9. But continuing medication treating the underlying dry disease was prescribed. So you can see the importance of the dry treatment for the patient's satisfaction after the cataract surgery is very important. Second, we should to know the patient's ocular surface disease is important before surgery. So how do we diagnose the patient with dry and how we classify? I think DUSE 2 has provided us a very good example. As you know, the DUSE 3 will come in a couple of months, but by the definition of DUSE 2, it's defined the loss of tear film homeostasis plus ocular symptoms. So with underlying pathophysiology like the tear film stability, hyperosmolarity, ocular surface inflammation damage, plus neurosensory abnormality. So we can classify dry disease into aqueous deficiency, evaporative, or mixed type. So in short summary, we screen the patient about their symptom with the many questionnaire like OSDI or DEQ5, and plus some homeostatic marker like non-invasive or invasive tear film marker. So far, I don't think that tear film osmolarity is quite popular among the many clinicians because of the a little bit, not inconsistent with the clinical diagnosis, but fluctuation is quite correlated well with the severity of the symptom. Therefore, last year in Taiwan, under our endorsement of TSCS, we published a dry eye disease consensus report. This report not only point out general guideline to general dry patient, but also emphasizes on the perioperative measurement of dry disease after cataract surgery. If you are interested, you can scan the QR code and refer to the paper for detail. According to our definition, dry eye is a composite disease of ocular surface and developed from the stability of the tear film, where local inflammatory process may result in manifestation of ocular symptoms that contribute to ocular surface damage. Why local inflammation are important in dry disease? This is the paper published in 2009 by Lam. He pointed out that the difference between patients without dry disease and dry disease, a significant difference in many cytokines like the interleukin-13, interferon gamma, AIOS6, or TNF-alpha. So it's important in terms of dry disease, the local inflammatory process. And what is the Taiwan-specific algorithm for dry disease? Not so much different, but we emphasize on, plus the, aside from subjective questionnaire, we adopt tear breakup time, either non-invasive or invasive tear breakup time, plus corneal fluorescein in staging the label of the dry disease according to the corneal fluorescence staining. And we also subtyped this dry into evaporative, aqueous deficiency, or mixed type. And a 4-step treatment for each severity is recommended. So we have to know that what's the prevalence and risk factor following dry disease. As you may, it's published in the literature, the prevalence of post-cataract surgery dry disease vary from 9.8% to 55.7%. The incidence from non-dry eye disease to dry eye after surgery may increase up to 31.3%. But we have to know that most of the patients have subtle of dry eye change but not identified yet. So it's very important to identify beforehand before this patient are planning for cataract surgery. This is a paper published last year in American Journal of Ophthalmology from our group. The aim of this study was to examine the initial presentation related to sex and identify risk factor of this concordance between symptom and sign of dry eye disease in Taiwan. Over 1,000 patients that was included analyzed. We found several strong predictors of the incongruity between dry symptom and the sign. That include age, gender, surgical history of cataract, pterygium, or conjunctival chalasis, and artificial tear use. Our suggestion is that ophthalmologists should prioritize symptom for female patients and those with a history of post-cataract surgery dry cases. We also, 3 years ago, published on American Journal of Ophthalmology to identify risk factor for ocular surface damage in aqueous deficiency dry eye disease. Why is it important? The patient are dry and risk for corneal surface disease, these are the highest risk for developing dry eye after cataract surgery. In our study, we found that diabetes, rheumatoid arthritis, and systemic lupus erythematosus was positively associated with systemic steroid was negatively associated with ocular surface damage in dry eye disease. This is why we found diabetes and some autoimmune disease. So talking about the pathophysiology mechanism, how cataract surgery affecting ocular surface, I think everyone will acknowledge the nerve transition, the different corneal nerve entrance during cataract surgery is important. So there's some doctors advocate use the superior corneal to avoid the truncation of the nerve. Other risk factors like the intraoperative lightening or preoperative use of topical anesthetics, and also the elevation of inflammatory cytokine, or with the increasing use of reflex surgery, some demonstrated damage within the flex. All very important. I think later on, Dr. Gita will give us a brief introduction of the Evapora dry, the meibomian dysfunction, its impact on the post-cataract surgery dry disease. It's very interesting. Our group also found that in patients with diabetes, dry eye is also very run risk for postoperative dry eye disease. What we found is that dry eye in diabetic patients with who were female sex and advanced age or poor glycemic control or microvascular complication like diabetic retinopathy or neuropathy, and those receiving ocular procedure like the intravenous injection or cataract surgery or transplantar vitrectomy, all at risk for developing dry eye disease after surgery. But very interestingly, we found some anti-glycemic medication like GLP-1 or agonist or SGLT2 antagonist, DPP-4, and insulin are superior to metformin alone in preventing DM-related dry eye disease. So it's here you can see the association between the cataract surgery or other intraoperative procedure that induce the dry in this specific cohort, I mean the DM patients. So let's we move to the treatment of dry disease after cataract surgery. What are the main needs exist in dry treatment guideline? According to these two, it identified gaps in like in head-to-head comparison study about different artificial tears, leading to non-conclusive guideline for artificial tears use in dry patients. Therefore, our study published another paper. We evaluated two artificial tears that containing hyaluronic acid in the post-cataract surgery dry eye disease. We recruited 70 patients and allocated this patient to two groups, HB-GUA HA group and CMC group, another brand name which contains the hyaluronic acid. Here is the study protocol. We evaluate and recruit a patient who developed dry 1 week after surgery. Aside from steroid and antibiotics, we just use a sustained hydration up diffusion, and then come back for 1 week and 3 weeks later. The primary endpoint was corneal fluorescein staining compared to baseline. Others, secondary endpoint like OCI, Schirmer's test, tear gap time, and corneal sensitivity was also assessed as well. Below are inclusion and exclusion criteria. So what we found that all the secondary parameters, they are all not significant. However, it's very interesting to find that HA group was superior to CMC-HA in improving corneal fluorescein staining as early as 1 week after surgery. So it means that it shows superiority over CMC-HA artificial tears. Why is that? We think possibly related to the variation in HA concentration, molecular weight, and additional polymer, because we know that the molecular weight of HB-HA in this study is high as 1,300 kilodalton, which is favorable in treating ocular surface damage. Additionally, the pH-D sensitive nature of FGV-GuAR leads to an increase in the viscosity on the ocular surface when they are exposed to ocular surface. So what Taiwan Dry Consensus Report suggests? Our study, our guideline suggests a more aggressive treatment of strategy, because to treat this patient to optimize their surgical outcome. So we have a specific surgical follow-up, which is recommended. I will give a short brief introduction. Most importantly, we should prioritize those patients who were at low, moderate, or high risk of dry eye disease, which were relevant to postoperative dry eye disease. So preoperative, we should aware of the patients about the possibility of worsening dry eye after cataract surgery. Especially pay attention to those who have asymptomatic incidence of dry eye disease, because they may develop dry eye after cataract surgery. Specific consideration intraoperatively, we should adopt to avoid all these factors that contribute to postoperative dry eye disease, and preoperative treatment should be aggressive. If the patient have the dry eye before cataract surgery, we should aggressive to treat this patient and downgrade their severity, so as to to proceed to the measurement of the ocular surface, some parameter, keratometry, topography, etc., and to improve the accuracy of your measurement. And then we have to stratify this patient, as mentioned, as to if they were at risk for dry eye disease after surgery. So it's very simple, not different, but we adopt a very aggressive treatment, because the patients, because of the corneal fluorescein staining, we interfere with the accuracy of the measurement. So we have to downgrade. If they are 3 or level 4, you have downgrade at least to 1 or 2, and then proceed to the refractive measurement, and then finally to go for cataract surgery. So this is the specific follow-up regimen. For this patient that possibly developed dry eye disease, early as 1 week or 2 weeks after cataract surgery, we have to check the tear gap time corneal fluorescein staining to evaluate if they develop dry eye disease after surgery. And also we have to adopt, as I mentioned, more aggressive treatment, starting at more advanced level. It's offered at 3 steps. First step, to inform the patient. Some patients, they are afraid of using the eyelid hygiene, so it's very important to use the wipes to clean up the excessive oil to avoid the contamination of their eyelid, or either develop infectious keratitis. Step B or C, which is indicate for patient with corneal lesion. In this patient, preservative-free artificial tears, Panta plug, or cyclosporine or steroid should be used. For more advanced disease, we should use the autologous serum for this patient. So the key takeaway here, dry post-change before, during, after cataract surgery, it will interrupt with the measurement accuracy, and also this satisfaction with the visual outcome. So screen diagnosis before cataract surgery is very important. And then we have to pick up or to certify this patient who are at high risk for dry eye disease. For example, autoimmune disease, type 2 DM or post-operative surgery cases. And finally, we should adopt a treatment strategy, aggressive treatment strategy for those patients who develop dry eye disease after cataract surgery. With that, I conclude my talk, and on behalf of the Taiwan Society of Cataract Refractive Surgeons, I welcome all of you to attend our annual meeting in conjunction with the third Global Young Ophthalmology Summit, which will be held in Taoyuan, Taiwan, very vibrant city of Taiwan. Thank you so much. Thank you. Next, I will introduce Dr. Gita Lai Iyer. She is a distinguished ophthalmologist over 25 years of experience in cornea and ocular surface disease. Dr. Iyer is a fellow of the Royal College of Surgeons in Glasgow and Edinburgh, as well as the Royal College of Ophthalmologists in the UK. She serves as the medical director at Cold Eye Care and holds an adjunct faculty position at the Singapore Eye Research Institute. As a founding member of the Cornea Society of India, Dr. Iyer serves as its president in 2021. Additionally, she is the managing editor of the Journal of Cornea Ocular Service. Dr. Iyer is also an Indian ambassador for the Tearfilm and Ocular Service Society, TIFOS, and also holds a position on its board of directors. Her presentation today is Management of Evaporative Dry Eye Disease, Power of Sustained Science. Let's welcome Dr. Iyer.
For that introduction, Dr. Sun, and a very good afternoon to one and all of you. I will be talking on the power of sustained science. I will be using the slide deck that has been provided by Alcon. I will also be interspersing the presentation with a few tips from my practical expertise with respect to dry eye management, and at the end of the talk I will also be sharing certain snippets regarding practical tips and pearls in the assessment and management of dry eye, and most importantly in choosing the appropriate molecule in different etiologies of dry eye. Dry eye is usually considered as a very dry topic, and but let's try and see how we can actually make this entire thing as interesting and subsequent to the talk as interactive as possible. So I think we've already heard about the overview of dry eye disease from Dr. Sun. We all know that dry eye disease is basically categorized into three subtypes: the aqueous deficient dry eye, the evaporative dry eye, and of course you have the variety where you have a little bit of both, which is basically what we refer to as mixed dry eye. As far as the prevalence rates of dry eye disease in India, though we don't really have a proper epidemiological study to tell us what exactly the rates are, we do have certain studies that have indicated a high prevalence of dry eye disease in India, and if I might add, dry eye disease is actually a pandemic that is waiting to erupt. Given the fact that today there is so much of exposure to digital screens, we see dry eye disease even in the tiny tots and those who are going to school. Apart from the aqueous deficient dry eye that you see associated with several systemic conditions and systemic medications that patients are on. So dry eye disease is no longer limited to any particular age group, and you can see dry eye disease through the entire spectrum of ages as well as in both the sexes. To put this in perspective, probably 4 out of 5 dry eye patients have some form of evaporative dry eye disease. So between the two types, evaporative dry eye disease is more common than the aqueous deficient dry eye. And when you look at the risk factors for dry eye, though this looks like a crowded slide, I think this is a slide that is packed with a lot of science as far as diagnosing dry eye disease is concerned. On one side, you have the aqueous deficient dry eye that is categorized into Sjogren's, non-Sjogren's, and the other disorders, which Dr. Sun beautifully captured in his talk on how these conditions have to be identified and ruled out before you touch a patient for cataract surgery, because you can end up having devastating complications if you do not identify the risk factors before you take up these patients for any surgery. For that matter, even refractive surgery, because today we have started seeing Sjogren syndrome even in the younger population who come to us for refractive surgery. On the other hand, we have what is broadly termed as the evaporative dry eye disease. So far, we have focused primarily on the meibomian gland dysfunction and have almost equated evaporative dry eye disease to just meibomian gland dysfunction, but we need to understand that there is more to evaporative dry eye disease than just meibomian gland disease. You can have systemic diseases which also lead to evaporative dry eye disease, probably through a meibomian gland dysfunction, but nevertheless something that needs to be considered in these patients. Ocular surface related, especially when you're dealing with patients who have allergic eye disease, vitamin A deficiency, and iatrogenic diseases. And of course, patients who wear contact lenses. And most importantly, probably what we will be touching upon, the blink related conditions which also lead to evaporative dry eye disease. So the evaluation of these patients actually starts right from the time the patient walks into your clinic. You're trying to appreciate how the patient is blinking when he or she is actually having a conversation with you and telling you what the complaints are. So history taking not only helps you in finding out what could be the possible risk factors that the patient has, but you also run a glance through the patient physically to understand whether there are any of the risk factors that would contribute to either aqueous deficient dry eye or evaporative dry eye disease. So when we talk about diagnosis, we have diagnostic tests, which most of us think is very exhaustive, which is time consuming, and therefore we tend to skip some of these tests and look for a quick fix to understand what would tell us whether the patient has aqueous deficient dry eye or meibomian gland dysfunction. I will put up a slide later on during the talk which summarizes what should be not just the tests that you do in these patients, but also the sequence in which it is performed, because that is equally crucial when you make a diagnosis of dry eye. You have different questionnaires. You can choose any one that you want to follow, but what is important is that you continue to follow the same thing constantly throughout for all patients, pre-intervention, post-intervention, and during all your follow-ups. Of course, you also have what is called as the blink test, which is what I was referring to, where you do have gadgets to actually capture not just the rate of the blink, but also the quality of the blink to make sure whether the patient is actually blinking completely or not. Because more often than not, it is partial blinks which leads to evaporative dry eye disease than an actual meibomian gland dysfunction. And to make this simpler, with respect to both the diagnosis as well as understanding the blink test, and to a large extent also the management that would be applied to these patients, is what is referred to as the dry eye wheel, which has three components. Basically, you have the mitigation, measurement, and the management arms of this dry eye wheel on the circumference of the wheel. And you also have from outside in, you basically have the different colors of the wheel, which gives you various management options with respect to the severity of the dry eye that the patient presents with. So this is how it is categorized into the simple to the more challenging, and based on what you measure, you will be able to offer management options that can start from lubricants and go up all the way to either a punctal cautery or management of the systemic conditions that the patient might have, which is again something that Dr. Sun referred to in his talk. So coming to an important question that we most often get asked is regarding the management. Given the fact that today we have a myriad of lubricants to choose from, The question that we are always faced with is, you know, what is the appropriate lubricant, or do you just randomly prescribe the same lubricant to every patient who comes to you with any kind of dry eye? Because after all, what difference does it make as long as the patient receives a, you know, any A, B or C lubricant? So let's just understand what is the composition of the lubricants, because this is what is going to help us understand how we would want to select a particular lubricant for a particular form of dry eye disease. And it is here that we have basically the components, which are either your wetting or lubricating agents, multiple action tear substitutes, and ocular surface modulators, each of which are highlighted here, the category of ingredients, which could either be the oily agents, the viscosity enhancing agents, osmoprotectants, antioxidants, and agents reducing inflammation, the presence or absence of which in the lubricant determines what you would use and in which condition, as I shall highlight a little later. Each of these ingredients have a particular role to play with respect to that aspect of the tear film that is the major problem in that particular patient, or in fact even in that particular eye. So you cannot really even compare the dry eye sometimes in the two eyes of the same individual, leave alone comparing the dry eye in one individual versus the other. And I shall take you through how the Sustain Adaptive Meshwork actually provides us a solution to most of the different forms of dry eye that we see in patients. So what is it that gives Sustain the power to act across all forms of dry eye? And this is a slide that beautifully highlights the various components and ingredients in Sustain, which provides you with the meshwork that ultimately ends up protecting the ocular surface, whichever layer of the tear film that might be affected. So it is a combination of HP guar, sorbitol, borate, and the demulsions, which vary in the different portfolios of Sustain, which tells you which one you would choose for which form of dry eye. And this is what is referred to as the adaptive meshwork, and these are the key features of the Sustain Adaptive Meshwork, whether it be the unique viscoelastic meshwork, the lubricant eye drops, which are maintained in a particular pH in the bottle, which ultimately ends up protecting the ocular surface. And all the components work together in tandem to ensure that your ocular surface basically improves following the use of these medications for that particular indication. So if you look at the various studies that have been done with respect to the use of Sustain, well, it has the unique ability to dynamically adapt to the tear film pH and the needs of each individual patient. You also have a change in the viscoelasticity of the drop as it leaves the bottle and falls on the ocular surface, which works in favor of the ocular surface when you instill the drop onto the eye. So this is the Sustain portfolio, where you have medications across the entire spectrum containing all the category of ingredients that was highlighted in an earlier slide. But how do you choose which for what condition is something that I shall come to a little later in the presentation. A word about Sustain Complete, which is not at this point in time a very new kid in the block. It's been there for some time, but probably I would say that it's not being put to its use as maximally as it should be, because this is probably the one gap that has been bridged in the management of dry eye disease, where so far in India we really did not have a lipid substitute, as you would like to call it, because we did have dicofosol in Japan, but we didn't have any lipid substitute in India so far. So this is that kid which actually bridges that gap and does have a role to play, especially in patients who have lipid deficiency dry eye, and where we basically highlight the importance of lipid-based artificial tears. So any recommendation comes only on the basis of evidence, and evidence is only based on studies that have been conducted. So when you look at this particular study which was done, wherein Sustained Complete was used in patients in a 6-month multi-center double-masked randomized controlled trial. This was something that compared Sustained Complete and Sustained Ultra. But to give you the gist of what this particular study had in terms of the outcome, was that with just 1 drop of Sustained Complete, you had almost an 8-hour improvement in the symptoms of these patients, which was consistent with Sustained Complete over Sustained Ultra with respect to long-term use, especially in patients with meibomian gland dysfunction and evaporative dry eye disease. So this is the gist of the study, which basically concluded that both of them had a role as far as restoring and maintaining tear homeostasis was concerned, with a slight marginal benefit that Sustained Complete had over Sustained Ultra in patients with meibomian gland dysfunction and lipid deficiency. So these are basically the key take-home messages, where especially with respect to the power of Sustain and the Sustain portfolio that you have, that for the dry eye disease, which is more prevalent, which is basically the evaporative dry eye disease, today we do have lipid-based artificial tears that are available in the market that can be provided to these patients, especially in the perioperative period, where it is extremely essential to keep these patients not only have a good ocular surface, but also keep them largely symptom-free and happy. So with this, what I'm going to do is I'm just going to shift a little bit of gear to the practical tips and pearls of applying what we have understood with respect to the ingredients that are present in the various lubricants, as well as understanding the sequence of the testing as well as the tests that would be performed. So what we normally recommend, this is the series of tests. It looks like you have to do a lot, but of course today we need to give a lot of emphasis, especially with regards the history. And it's extremely important that you do the tests in the order of minimally invasive to maximally invasive. So you do not dilate the patient, you do not take the applanation attention and then start the dry eye evaluation, because that is something that's going to entirely skew your diagnostic tests. You will have corneal staining if you have done 80 in a patient and then you take a look at the patient. And corneal staining and tear breakup time, like Dr. San mentioned, are the 2 most important tests. If you ask me what is that one test that you would want to do to know whether the patient has aqueous deficient dry eye or evaporative dry eye disease, because you have a very busy OPD where you don't have enough time to provide to the patient, just put the fluorescein stain on the surface, look for the tear breakup time. If it is shortened, you know you're dealing with some form of evaporative dry eye disease. If there is significant corneal staining, you know that you're probably dealing with some form of aqueous deficient dry eye, which will give you a direction to go ahead as far as understanding what the root cause of the etiology in that particular patient is. So this is in a nutshell to tell you what all you need to do if you do have adequate time with respect to diagnosing the dry eye. And this is a small video to show how exactly you would do the staining. I hope it doesn't come. Okay, there is a. So that's the fluorescein strip, and we would normally use whatever is available on the table with us. So we end up using sometimes an anesthetic drop, we end up using an antibiotic, we end up using a lubricant. So this is just to show how we need to do the staining, but what was important to document here is that the wetting agent for the fluorescein should always be normal saline, because whether you use, when you use any of the other wetting agents, you actually end up altering the ocular surface. So when you use an anesthetic agent, you will end up having more corneal staining. When you end up using a lubricant, you may actually mask the staining on the surface. So right from the wetting agent that you use on your fluorescein strip, you need to know what should be put onto the surface in order to get a good outcome in these eyes. This is again another video to show you how you need to do a dry eye evaluation. A quick look at the entire surface, look at the eyelashes, the lid margin for thickening, for telangiectasia, look at the superior bulbar conjunctiva for hyperemia, for chalasis and for congestion, look at the inferior fornix, look for presence of any cicatricial changes, look at the medial canthus for any evidence of medial canthal keratinization, look at the other eye. Look, this is a patient who has superior limbic keratoconjunctivitis. Make a general impression of the tear status, whether it is moist, whether it is dry, whether there is a lackluster appearance. Specifically look at the puncta always in these patients. And if you forgot to look at the other eye, go back and look for the puncta of the other eye. So this is something that tells you how you need, make this a habit, do this for every patient, check with the cobalt blue filter and the staining, look for the T-butt, the conjunctival as well as the corneal staining, especially when you have a yellow barrier filter. Look for lid viper epitheliopathy because this is again something that causes significant symptoms. Look for active tear secretion in the superotemporal quadrant from the palpebral lobe of the lacrimal gland. And the last thing that you will do is to express the meibomian glands because that is what is maximally invasive, and you're secreting the meibum out of the glands, which will totally alter the staining as well as the tear breakup time if you do that before you do any of the other things that I mentioned. This is basically to show how you would time your tear breakup time after instilling the fluorescein. Count the number of seconds to the appearance of the first random black spot, and that is what tells you what your fluorescein tear breakup time is. This is the conjunctival as well as the grading for the corneal staining. I know my time is up. My slides are also kind of done, but I'm just going to wind up with this slide, which beautifully captures the different forms of dry eye disease as far as the T4's deuce 2 report is concerned. And this was one publication in the Journal of Cornea and Ocular Surface, the official journal of the Cornea Society of India, where we published extensively about the artificial tear substitutes and the current Indian scenario. This is a slide which again captures similarly the earlier slide that I showed about the various ingredients that are present in lubricants. And this final slide is related to the choice of ingredients when you're dealing with aqueous deficient dry eye, when it's mild, moderate, severe, the components in the lubricant that you would opt for when you're dealing with aqueous deficient dry eye and for evaporative deficiency dry eye. And this is something that is freely available for all of you to download and go through from the Journal of Cornea and Ocular Surface. And I also invite for submissions as the managing editor of this journal of interesting case reports and articles that you might want to send for submission to this journal. So with this, I come to the end of this talk, and I would like to acknowledge my colleague, Dr. Bhaskar Srinivasan, as well as the entire team at Code Eye Care, an Institute of Excellence in Chennai that we have recently embarked upon, which basically stands for Cornea, Ocular Surface, and Dry Eye. Thank you.
Thanks, Dr. Iyer, for your wonderful presentation, detailed explanation of the classification and treatment guideline for dry eye disease. Is there anyone in the audience have any question or comment? I think this presentation is very relevant to clinical practice because I know India is a very huge, large population, and in the past few days, I've seen a lot of wonderful technique in terms of cataract surgery. So every day we have a lot of cases, but you know the ultimate goal is to make patients satisfied with the surgical outcomes. But we know that a lot of patients nowadays, especially for our people who are getting old, who are also at risk for developing dry eye disease at the time of receiving cataract surgery. So it's very important to identify beforehand this patient, especially they have dry disease, and especially when they asking for the premier lens, like the correcting both the astigmatism and presbyopia. So it's very important and relevant issue. Is there anyone have any comments or questions? I have a question for Dr. Iyer. I've noticed that you're expert in evaporating dry disease. So, do you have any specific approach to identify this patient if they have the meibomian gland disease? For example, evaporating dry disease, do you have any different approach to them, and how would you manage them accordingly?
Yes, I think especially given the fact that meibomian gland dysfunction is something that we see so commonly, the first thing that we do is to understand whether the patient is symptomatic and has signs, because like you rightly mentioned, symptom-sign discordance is something that is very common, especially in evaporative dry eye disease, where patient might be very symptomatic, you may not be able to see something on the surface, and the other way around, which becomes important when you're taking up the patient for cataract or refractive surgery, because if the patient has signs but is not symptomatic, the surgery might actually push the patient to becoming symptomatic, and then the patient blames you for the symptoms that the patient has developed, which is actually speaking not related to the surgery per se, but due to a pre-existing condition. So what we normally do in these patients is always take a look, have a very detailed history. So we normally have a history that cuts across almost 35 plus questions, which gives us an idea about any underlying factor that may be responsible for this. Before the patient has undergone any test, we evaluate the patient's blink, and subsequently we also evaluate for the non-invasive breakup time. So if you have access to gadgets that help you, so we do the non-invasive breakup time. Then we do the clinical evaluation with the fluorescein, and then finally do a meibography, because again for that you have to evert the lid, which alters the ocular surface. So like I mentioned, from the minimally invasive to the maximally invasive tests, understand again on meibography whether the gland structure is altered. Sometimes you can have significant loss of meibomian glands where none of your thermal pulsation or pulse light therapy might really be beneficial to the patient. So understand all that, and then subject the patient to a kind of a step ladder approach with respect to using lubricants, prescription drugs, and then escalating it to the next level of either thermal pulsation or the pulse light therapy. Always also look for Demodex in these patients, because that is something which we have seen contributes significantly to evaporative dry eye disease. And so we normally pull out the lash and actually look for the Demodex under the microscope.
Yeah, I agree. You know, for patients, especially for those without symptoms, okay, without symptoms, but they have severe meibomian gland disease or evaporative dry, especially those of the short breakup time, but they don't complain or even no signs of ocular surface staining. Would you directly treat this patient? For example, aside from the hygiene, would you put on, for example, the thermal pulsation treatment or IPL for this patient before you proceed to cataract
Yes,
surgery?
if the patient has to be taken up for cataract or refractive surgery, then definitely yes. I think it's better to be aggressive pre-operatively rather than have unhappy patient post-operatively. Yeah.
I also noticed a very interesting slide on your presentation. You found that a substantial portion of the patient that have dry disease, especially in diabetic population. Do you want to mention more about this? Because it's very interesting. Nowadays, we refer our patient to retina specialist for diabetic retinopathy. But I think maybe in the future we should send our patient for dry eye or cornea checkup to detect the subtle changes of diabetic keratopathy. What's your opinion about this? Would you mention more about this. It's a very universal phenomenon in India too. I mean, the diabetics in dry.
Absolutely. I think we've all, as cornea specialists, we've always taken the responsibility of having a retina opinion or a glaucoma opinion in patients who might have diabetes or other conditions that lead to optic nerve or retinal problems. It is time for us to create that awareness amongst the other specialists that when you have underlying diabetes, dry eye is not just a term which anybody and everybody can treat, but actually these are patients who require a very detailed and proper evaluation of their dry eye by the cornea or the dry eye specialist. The use of the general term dry eye sometimes minimizes the seriousness of the problem that patients can actually have because of dry eye. And I think as prominent people, we should all take it up as a cause whereby we keep advocating for the need for a detailed dry eye evaluation even in diabetics, especially at least in the preoperative patients, because these are situations where you can have them coming back to you with problems, because post-operatively the patient will definitely be referred to you when the patient is unhappy. But I think we need to emphasize that even pre-operatively, the cornea or the dry eye specialist needs to evaluate these patients to identify if they are at risk for developing dry eye after the surgery.
Yeah, I totally agree. And I found it a very interesting point, not only in your presentation, but I also found several, some doctors from Japan, they advise the exercise of eye blinking. You know, nowadays we are using multi-screen. For example, I watch the audience. I also look at you and the video terminal display here. So we use a lot of time to spend on the screen. So it's very important to adopt the, a blinking exercise. Do you have any special advice for this patient?
Yeah, so I think the first thing would be to identify that that the patient has a problem with his or her blink and make them aware. So we normally take a video of the patient blinking on the slit lamp and actually show them what happens when they have a partial blink, whereby the inferior cornea continues to remain dry because of a lack of complete blink. And once we make them understand, we tell them that they need to consciously blink more often when they are looking at digital screens. It's not just about the quality of the blink, but lack of blink also leads to reduced meibomian gland secretion. And these are things that one has to inculcate as a habit, because not just the software professionals, but today all of us are working with gadgets and screens, and therefore all of us need to be aware that blinking is as crucial for ocular surface health as is the tear film.
Yes, I don't know what's your situation. In our hospital, we always use the non-contact tear breakup time, and also document the blinking pattern of this patient, which we call the keratograph. So you can record the blinking pattern, and you can document the incomplete blinking rate over a period of blinking. So with that, we advocate our patient to, voluntarily note it. You have to blink, for example, more than 10 times a minute. It's a self-training to squeeze out the meibomian gland to prevent the occurrence of the evaporative dry eye. I think it's very important in terms of preventing lower incidence of dry eye before surgery or after surgery.
I think that's a very important point that you have made, Dr. Sun, because I think just like you have these phones which tell you that you're holding it too close, move it back, you should probably also have a prompt blink. So, because you're so glued to your screens nowadays that you do only things that your screen tells you to do. So I think we need to have some kind of a prompt that comes on your phone and you enable that to tell you to blink, because how much ever we tell patients to do it consciously, when you're working on a monitor, sometimes it becomes, but I completely agree with you on that point that one needs to blink more consciously. We all do have the non-invasive tests. You said the keratograph. Yes, we all do these tests, but not every ophthalmologist in the country will have access to all these gadgets, and therefore when we give guidelines, we will have to ensure that these guidelines are based on the diagnostic tests which are available to everybody. Simultaneously also have diagnostic tests or guidelines that are available to dry eye specialists or cornea specialists who have access to these gadgets. So it will have to be all inclusive.
So is there anyone on the floor have any question or comments? Okay, welcome.
Good evening, madam.
Good evening.
Madam, blue light filter, some optical shop encouraging blue light filters for dry eye and other thing, but AAO not accepting this. What is your opinion regarding blue light filter
So this
glasses?
is a question that we constantly keep getting asked. I hope you got the question. The blue light filter in the glasses, is it really protective or not? So I think the verdict is yet to be out, though whatever evidence is available at this point in time, at least the studies that have been conducted, there is no superior effect of this filter in terms of the dry eye that occurs when you're looking at the monitor. But having said that, there is no significant harmful or downside to the use of it. There have been studies which have compared, which at this point in time mention that it might not have a significant beneficial effect. There were similar studies which were done for the use of omega-3, if you recall. There was the DREAM study which said that it might not be beneficial. But sometimes some of these verdicts may not be all inclusive, and we will have to use our own discretion and judgment when we advise something specifically for a particular patient, and it is always done on a case-to-case basis. Dr. San, I would like to have your opinion on this also.
Yeah, I think I agree with Dr. Iyer. There is no conclusive study about the protective effect of blue light filtering on dry eye, even on the, a major debate is that they use the blue light filtering intraocular lens. Will they prevent subsequent AMD development? According to a recent study from our hospital, we found that we used the national database, and we found no difference in the development of AMD. So it depends on, I agree with, it depends on personal experience. Some patients may, they feel comfortable while they use the blue light protection goggles or filter. I think, well, okay, keep using it. But there's no conclusive evidence. It just mentioned about the DREAM study about the omega-3 on the dry eye, which you take advantage of the anti-inflammatory property of that medication. But yeah, it did not reach the conclusive evidence. However, when we look into detail, the subtypes, the stratification groups, it may have some benefits, but not conclusive. So maybe due to the sample size or long-term, study to lead to the conclusion. Yeah, I agree with Dr. Iyer. Yeah. Okay, thank you. I think we're just on time. It's 4 o'clock, and with that, I thanks to my co-chair, Dr. Iyer, and all the audience to participate in this wonderful section, and also appreciate Alcon India for their generous support to this symposium. Okay, thank you. Thank you.
Thank you.